Welcome to the second lecture in the Navigating Paediatric Palliative Care e-learning series, a guide to communicating with children and families at end of life. This lecture will briefly examine talking to families about accessing palliative care services, advanced care planning, and end-of-life decision-making, talking to dying children and young adults about illness and death, and supporting children and families through anticipatory grief. Communicating with children and families nearing the end-of-life stage can be a challenging, draining, and stressful experience for many clinicians, who may feel they lack the necessary experience, training, or skills to start and maintain these difficult conversations. This lecture is designed to provide an overview of why communication is important and strategies for effective communication with palliative children and teenagers and their caregivers. Here, the initial hurdle often relates to the discussion around the need for initiation of palliative care services. Generally, this conversation will be started by a member of the medical team, like a specialist nurse or paediatrician, but it is important that all members of the wider team are able to engage in these discussions to facilitate early identification and referrals. Here, we can explain the role of different team members in providing care to facilitate comfort and the different settings in which services can be provided to maximise duration and quality of life. Accepting palliative care services and planning for end of life requires some degree of acceptance of the diagnosis and impending death itself, which can be very traumatic for parents and caregivers and may manifest as disinterest, reluctance, or refusal to engage in these conversations. We can support parents and caregivers through this process by explaining that advanced care planning, while undeniably distressing, can help to ease their burden at the time of their child's death. It can minimise the risk of children undergoing unnecessary treatments and can avoid forced decision-making under pressure. Where appropriate, depending on their age and capacity, children can and should be involved in end-of-life decision-making. When it comes to talking to seriously ill children and teenagers about death, it is imperative that, first and foremost, we are aware of and guided by the family's wishes. Many parents, understandably, find the decision to discuss death and dying with their terminally ill children a difficult one. Here, they are guided by their own instincts, their child's condition, their knowledge of and relationship with their child, and their cultural or spiritual beliefs. Regardless of the parent's decision, it is important that health professionals provide impartial advice and support and present a united front. This can be challenging for professionals, especially if the parent's decision does not marry with our own expectations or beliefs. But we can play our part in educating parents and caregivers about these topics and consulting with the family to find out what they do and do not want discussed with their child. Some professionals will recommend open and direct communication with children about their prognosis at all times, from as early on as possible, whilst others may say it's only necessary to tell the child as much as the child asks to know. Regardless, this will vary depending on the needs, experiences, and circumstances of the individual child and their family. It's important to note that, in the case of terminal illness, uncertainties about the future often provoke a profound sense of loss of control, especially in paediatric populations, where we know that prognosis can be particularly variable. Studies show that children often wish to be informed about their illness and plans for treatment, as this helps them to retain some degree of control. Although children's information needs may be age-dependent, most will worry about the impact of their disease and medical treatments on their lives and on those around them. Studies also show that when information, even if unfavourable, is withheld from children, the child's fears and feelings of uncertainty are exacerbated. This is not to say that all terminally ill children will want to talk about death and dying. Of course, they might not. But if we allow children to talk to us about death, We allow them to have time to prepare, time to share and create memories, time to plan, and time to say goodbye. Discussing and validating their concerns and feelings shows children that we value what they have to say and means that they will be more likely to communicate openly in the future. Some parents and professionals buy into the belief that children are not able to understand the concepts of death, or that talking about death will cause the dying child to become deeply depressed or to give up, so discussions around this topic should be avoided. This is not necessarily the case. Children have varying thoughts and concepts of death according to their age, developmental level, and life experiences, and are often more aware of death and dying than adults may realise. Whilst it's obvious that the way in which we engage in these discussions will vary greatly between interacting with a young child and an adolescent, which incidentally will be further explored in the subsequent reading for this topic, it is important that we are aware of what children are typically capable of understanding at different ages and stages of development to ensure that discussions can be maximally effective. Generally speaking, young toddlers, 2 years and under, are unable to comprehend the meaning of death, but can detect significant absences and disruptions to their routines. In the preschool years from ages 3 to 5, children understand death to be a temporary, reversible, and impersonal state. From the ages of 6 to 10, children develop curiosities and can grasp the finality of death, but often struggle to relate it to themselves and those around them. It is not until children reach the age of 11 that, generally, they are able to develop a more sophisticated and realistic view of death. They realise it to be irreversible and that it will happen to them and their loved ones eventually. But they also appreciate that those left behind need to grieve, find meaning, and remember. These norms are often challenged in children with fatal illnesses, though, who are able to detect physiological changes in their bodies and are sensitive to the reactions of parents and hospital staff from as young as 3 or 4 years of age. This again highlights the importance of integrating factors other than the child's age or developmental level solely when it comes to making decisions about discussing end of life. So, if the child's parents have made the decision to keep them informed and are happy for care providers to engage in conversations around death and dying, how do we proceed? Again, this depends on the age and developmental level of the child or teenager, in combination with a myriad of other factors. But one model proposed by Beale, Bale, and Aaron involves 6 E's and can be modified to suit the needs of the individual patient, depending on the language used. The first E relates to establishing a communication agreement with parents, children, and caregivers as early on in the relationship as possible. The second relates to engaging the child at the right time, such as at the point of diagnosis or during acute care episodes. Actively attending to signs of significant behaviour change that suggest that the child is struggling with emotions will provide an opening for discussing the illness. The third relates to exploring what the child already knows and wants to know about their illness. This allows for the correction of misperceptions and misunderstandings about the medical facts. The fourth relates to explaining medical information according to the child's needs and age. Asking, "What would you like to know?" or "What have you been worrying about?" will allow you to specifically answer key information needs if the child wants to know. The fifth relates to empathizing with the child's emotional reactions. Allowing a child to be upset and express feelings while providing physical comfort may be painful, but is important to facilitate discussions of more concrete concerns. A strategy for addressing a child's emotions includes empathizing. "I can see that you've really been worried about this." Validating. "We've been wondering why you've been upset." And clarifying. "Can you tell me what it is you've been thinking about?" The sixth and final E relates to encouraging the child by reassuring him or her that you will be there to listen and to be supportive. But here it is important to be wary of providing false hope through saying things such as, "Everything will be all right." Finally, we will briefly examine anticipatory grief and how to support children and families in dealing with this. Anticipatory grief refers to a grief reaction that occurs before an impending loss. Typically, the impending loss is a death of someone close due to illness, but it can also be experienced by dying individuals themselves. Anticipatory grief is common in parents and caregivers of children with disabilities or life-limiting illnesses, and can present with varying degrees of frequency and intensity, depending on the child's stage of illness and the typical developmental or lifetime milestones commonly associated with their age. From early walking and talking milestones through to starting and completing mainstream schooling, getting a driver's license, a job, and getting married or having their own children. In palliative care, anticipatory grief often involves depression, extreme concern for the dying person, preparing for the death, and adjusting to changes caused by the death. It may not always occur and does not mean that the grief felt before is the same as the grief experienced after death, or that after death grief will occur for a shorter amount of time because there has already been a period of grieving. It is crucial that health professionals are aware of anticipatory grief so that they can be sensitive and responsive to the attitudes, needs, and feelings of parents and caregivers. If you are concerned about a child or family, it is important to acknowledge their grief and concerns before referring on, with their consent, to appropriate counselling services or flagging them with another team member who is perhaps better equipped to support them. Here, it is especially important to be in tune with your own feelings of grief and to engage in effective self-care, which will be further examined in the final lecture of this Navigating Paediatric Palliative Care e-learning series.